8:01 or something. So why don't you take it? And
yeah, people will trickle in, but we might as well get started. So yeah, it's honor for me to introduce Dr. Marmar Vaseghi. She's an associate prof at the UCLA. She's a EP doc who does a lot of research as well. She's received her MD from Stanford University and master's in clinical research and PhD in molecular, cellular, and integrative physiology from UCLA. Her lab has taken a big interest in looking at the mechanisms behind novel therapies to look at sudden death and ventricular arrhythmias. She's a PI and co-investigator in several NIH-funded grants, authored over 100 peer-reviewed publications. Her lab has over a decade of experience in developing and using porcine and mouse infarct models to better understand mechanisms of arrhythmias. Currently, she's the director of Clinical and Translational Research at UCLA Cardiac Arrhythmia Center, involved in very many clinical trials and mechanistic studies and translational studies in porcine and mouse models for cardiovascular disease. She's also an associate editor for JACC Clinical EP. She's today going to discuss sympathetic modulation of ventricular arrhythmias and clinical insights. This is something that we've had very minimal experience with this in Calgary for clinical use. And it's definitely one of the tools that we want to learn more about in managing patients with difficult ventricular arrhythmias, especially when traditional treatments fail or don't have a role, such as antiarrhythmics and ablation. So thank you, Dr. Vaseghi.
Thank you. Thank you so much. Thank you for the invitation. It's a pleasure to be here this morning. Good morning, everyone. I'm going to be speaking to you about sympathetic modulation of ventricular arrhythmias and clinical insight, and so focus on one of the branches of the autonomic nervous system. But I will tell you that there is this whole other field studying the other branch that's just as important, and that these branches do interact. But for the purposes of the hour that we have today, I thought I would go through some of the work that's been done in the past decade, looking at sympathetic modulation in the setting of structural heart disease, as compared to, let's say, for channelopathies and long QT syndrome, where the work actually dates back even further, and showing you some of the work we've done in our lab or work other people have done to move this field forward. So these are my acknowledgements and the people that primarily support the work in my lab. I was going to go through, for those who are not familiar with this field, about the anatomy and the physiology of the cardiac autonomic nervous system, some of the changes we see in the actual autonomic nervous system in the setting of cardiovascular disease that promote ventricular arrhythmias, and then the neuromodulatory therapies for ventricular arrhythmias that are currently up and coming and in development and or actually being used at the bedside for patients. So there's a couple of key things that I just want everyone to hopefully take away from the talk today. One is that, neural signals that are generated by the heart are integrated at several levels along the autonomic neuroaxis. And so you have signals that the heart gives in terms of how it's doing to the intrinsic cardiac nervous system, which are those ganglia that are sitting predominantly in the back of the left atrium. They integrate those signals and can change output in terms of neural transmission to the heart. There are signals that go through the stellate ganglion. Those are afferent signals that can then change how the stellate ganglion responds in terms of its sympathetic output to the heart. There are signals that go through the dorsal root ganglia to the spinal cord, where there is a level of processing that can occur and reflexes that can occur that can then subsequently change the output to the heart. And then there is a whole level of afferent signals that go through the nodos, or the inferior vagal ganglion, to the brainstem. And those signals can get integrated to the brainstem, not just at the level of the parasympathetic nuclei, but also at the level of the rostroventrolateral medulla and the sympathetic centers. And they can actually then change efferent output to the heart, both through the spinal cord as well as through the vagus. So you have multiple levels where signals are getting integrated. This becomes important because when we cut off one level, we kind of have to think about at what nexus point or point we're going to decide to modulate the neurotransmission to the heart in order to achieve the results that we want for therapies. In terms of the sympathetic ganglia, just a brief bit of anatomy. So the stellate ganglion is a fusion of the thoracic and the cervical ganglion that's supposed to lie here. And then the T2, T3, and T4 thoracic ganglia provide cardiac innervation to the heart. The neurons that lie in these ganglia are postganglionic sympathetic neurons, and they receive preganglionic input from the spinal cord. This ganglion kind of lies behind the parietal pleura, and the nerve fibers then subsequently at the level of the thorax actually join branches of the vagus, and they come down through that area of the mediastinum, kind of around the trachea, and go on to innervate the heart. Now, the heart is encased in nerves. This is a cleared mouse heart, so where you don't see the muscle and the fat anymore, but you basically just see the nerve fibers. And this is PGP 9.5 staining, which is a pan-neuronal marker. What you can see is that literally there isn't a location, right, either in the atrium or the ventricle that doesn't have nerve fibers. You can see the ganglia that are sitting on the back of the left atrium as sort of these chains of neurons that almost form these interconnected cities. And then this is tyrosine hydroxylase staining, looking at the sympathetic nerves of the heart. So really anywhere that you look, you will see nerves. And this has implications for when we do catheter ablation. When we do catheter ablation of the heart, we're not just modifying the myocardium, we're likely also impacting the nerves that lie in that area. So, way back in 2003 now, Kawana and colleagues actually took human hearts and they looked and see what type of nerve fibers were in the human heart and where they were predominantly located. And they were able to see both TH positive, those are the tyrosine hydroxylase sympathetic nerve fibers, and then the acetylcholinesterase positive, or the parasympathetic nerve fibers that were located both in the LV and the RV, with slightly greater proportion at the base as compared to the apex. And you can see here the atrium as compared to the ventricle had more parasympathetic nerve fibers, but that the sympathetic distribution between the ventricles and the atrium, was pretty similar. Ventricles are slightly less still, showing that basically you have both sympathetic and parasympathetic nerve fibers that innervate the left ventricle and the right ventricle, as well as the atria. So one of the controversies I think that had lived a long time in the field of structural heart disease especially was since left sympathetic cardiac sympathetic denervation had worked so well instead of long QT, people always wondered if that was enough, or maybe the left stellate ganglion was all that ever innervated the left ventricle, and so we never had to really worry about the right stellate ganglion. So the question that we are asking back in 2012 was, well, these sympathetic nerve fibers, do they really just come, when it comes to the left ventricle, from one stellate? Can we say that, let's say, right stellate innervates the right side of the heart and the left stellate innervates the left side of the heart? And so for this study, we just took a porcine heart, you can see it here, and we used our standard, duodecopolar catheter, placed it on the left ventricle. And then next to it, we actually put in a microdialysis catheter to measure norepinephrine levels. And what we found is that this, at least for this anterior aspect of the left ventricle, when you stimulated either the left stellate ganglion or the right stellate ganglion, that norepinephrine concentrations similarly increased. There wasn't a clear region of the left ventricle that was only innervated by the left stellate ganglion. Both stellate ganglia, when they were stimulated, would increase norepinephrine, interstitial norepinephrine levels as measured by our microdialysis catheter similarly. The other thing I think that we noticed, let me see if I can go forward now, is that when we looked at some of our markers of electrophysiological markers, whether it was T peak to T end interval, which is a marker of sudden cardiac death, or whole heart dispersion or repolarization, which is just looking at the variances in repolarization time across the heart, whether you stimulate the left stellate ganglion, the right stellate ganglion, or both stellate ganglia, you got similar increases in your T peak Tn interval on the surface electrocardiogram. And you got similar increases in whole heart dispersion or repolarization, suggesting that both of these were potentially pro-arrhythmic, that there wasn't just one stellate that was responsible. Now, if you've ever done stellate stimulation, one of the things you'll notice, these were sort of surface recordings that we were obtaining from a sock electrode, is that when you do stellate stimulation, you start noticing really huge T wave changes. And you also start getting more triggered activity, which can even in a normal heart initiate VF, suggesting sort of the powerful effects of the sympathetic ganglia when it comes to causing arrhythmias. there's just one other thing that I want to point out about the anatomy before I move forward, which is that, we talk a lot about the stellate ganglion, the T2, T3, and T4 thoracic ganglia. And these are the ones that we modulate when it comes to cardiac sympathetic denervation, or the stellate ganglion when it comes to stellate ganglion block. But behind the left subclavian artery on the left side, and actually the right artery on the right side, there's this little ganglion called the middle cervical ganglion. And if you go back to studies that were done over 20 years ago when people injected dyes into the heart and looked to see where the neurons of the heart were located along the sympathetic chain, what they found is that there were many neurons in the middle cervical ganglion. And in fact, when we went ahead and we started doing studies on repolarization changes that we saw, or action potential duration changes that we saw when we stimulated the middle cervical ganglia, I'm just going to briefly summarize the study by saying that whether we stimulated the stellates or the middle cervical ganglia, we actually saw similar increases in action potential duration. The action potential changes by stimulating either the middle cervical ganglion or the stellate ganglion were similar, suggesting that the middle cervical ganglion actually does provide important postganglionic sympathetic innervation to the heart. And this ganglion is not affected at all when we do cardiac sympathetic denervation. Generally, we just take out the lower half of the stellate down to the T4 thoracic ganglia. We cut basically here. So when we say cardiac sympathetic denervation, we're not really denervating the entire sympathetic input to the heart. We're just kind of shifting it potentially in the right direction. Okay. So the other important aspect that has, was kind of being shown in all of these physiology studies 3 to 4 decades ago, but really didn't reach us as cardiologists and electrophysiologists, is that there are other sort of neurotransmitters and peptides that are released in the setting of sympathetic activation. So our basic understanding of sympathovagal balance back in, 20 years ago was that, well, you had norepinephrine and you had acetylcholine. And in a normal state, you had a higher vagal tone, so that there was more acetylcholine around at the nerve myocyte interface, and this would inhibit norepinephrine release. Well, and on the other hand, if there was, in the setting of sympathetic excitation, norepinephrine could potentially bind to alpha receptors that were located on parasympathetic neurons and inhibit acetylcholine release. What we know now is that in the setting of a normal sympathovagal balance, there are actually other neuropeptides involved, neuropeptide Y being one of them, but there are others, including galanin, on the sympathetic sides. And there are actually other neuropeptides involved on the parasympathetic side. And these also have kind of these presynaptic inhibitory effects. So in the setting of post-myocardial net sympathoexcitation, you get norepinephrine release and MPY release. And both of these can bind to their receptors on the presynaptic parasympathetic nerve terminals and inhibit acetylcholine. So that it's not just that you have a lot of norepinephrine around, you have to account for the effect of these other neuropeptides. One, for which we have no blockers at the moment, and two, whose effects are much longer than our standard neurotransmitters. Neurotransmitters at most will stick around for a few minutes. Neuropeptide Y has a half-life of 20 minutes, and so 5 half-life is on the order of hours. So this is sort of something that's new and has come about. Like I said, we don't really have any blockers currently in the field of medicine that is looking at either Y1 or Y2 receptor blockers, but something to keep in mind when we do neuromodulator therapies, that we're not just affecting norepinephrine levels, we're also affecting neuropeptide Y levels. And when we studied neuropeptide Y with BIBO, which is a neuropeptide Y1, that's the receptor that's on the cardiomyocytes blocker, what we found is that neuropeptide Y in itself, in the setting of high dose propranolol, also can shorten action potential duration. So we took these animals and we gave them high dose propranolol and went ahead, stimulated the stellates, and we saw about a 20 to 30 millisecond action potential duration shortening despite 1 mg per kg of propranolol, which, as many of you know, is something like 5 to 10 times ACLS recommended doses of IV propranolol. But when we gave BIBO, which is a Y1 MPY1 blocker, that change was significantly mitigated, again, suggesting that at least neuropeptide Y through the Y1 receptor on the cardiomyocytes can in itself shorten action potential duration. And if you block it, then you can potentially make the tissue more refractory. So there's a lot of work being done sort of on these other neuropeptides that are potentially at work that we affect with our neuromodulatory therapies that go beyond just the beta-1 receptor and norepinephrine. So what about diseased hearts? Now looking at sort of neural modeling that we see in diseased hearts. As many of you know, infarcts in humans are not these homogeneous, nice scars. They're made up of these very complex tissues where you have normal myocytes, necrotic areas, blood vessels, and in general, we tend to think that ventricular tachycardia or ventricular arrhythmias live in these isthmuses of these diseased tissue where the live myocytes actually contribute to the existence of these circuits, and that these live myocytes, because they're sort of interspersed within scarred disease tissues, they have slow conduction and so alterations in their effective refractory period that allow for this circuit of ventricular tachycardia to exist. So the way we've been treating scar-mediated VT is generally by blocking conduction and or making tissue more refractory with ablation. But what we can potentially do is achieve the same thing using our neuromodulatory therapies. We can make tissue more refractory by blocking sympathetics or stimulating parasympathetics. And so what I want people to think about when they think about how VTVF occurs is that you need a heterogeneous substrate. Again, this is a sort of a mouse heart where we're looking at the actual changes that occur in the myofiber orientation and scarring at the level of an LAD infarct. So you need a heterogeneous substrate. That's definitely true. That gives you that electrical ion channel gap junction remodeling and fibrosis. But you also need to be able to dynamically modulate this scar with the neural modeling that subsequently occurs as a result of myocardial infarction or myocarditis or non-ischemic cardiomyopathy. And so it's really this dynamic modulation by sympathetic activation and parasympathetic dysfunction that, let's say at 4 a.m. on Sunday morning, causes that sudden death, whereas a patient may have had and carried that infarct with them for years before they develop VTVF. And in fact, many of the therapies that we have that currently have been shown to reduce mortality and sudden cardiac death in the setting of structural heart disease aim not just to modulate the myocytes, but are really aimed at the neural remodeling and the nervous system. So what really happens as a result of inflammation and or scar or disease when we have in the setting of structural heart disease? So this was a study that was done by our Italian colleagues back in 2014, where they used carboxy-11 hydroxyephedrine imaging, which is essentially sort of a marker of sympathetic nerve fibers. And what they found was that in patients who had the greatest amount of denervation, right, after their myocardial infarction, those patients were at the highest risk of sudden cardiac death. And that there seemed to be this range with the ones who had the lowest amount of denervation being at lowest risk. So there is clearly after inflammation or myocardial infarction, a certain amount of denervation that occurs. Those nerves are just as likely to be damaged as the myocytes as a result of the same process. And that in itself sets up problems in terms of when it comes to now the sympathetic nervous system getting activated and the heterogeneities that you see in activation and repolarization that can set up the circuits. And so this was a study done way back by Doug Zipes in 1983, where he created these LAD first diagonal infarcts, and he stimulated the left and the right sympathetic ganglion. And the take-home point was that there were areas above the infarct that for the most part would basically shorten their effective refractory period with left-right stellate ganglion stimulation norepinephrine. But there were areas below the infarct, sort of in this region, that either didn't respond to sympathetic stimulation or that did respond to sympathetic stimulation. So now you have these areas sort of in the peri-infarct zone where you have both responses to sympathetic stimulation, they will shorten the action potential duration, and no response to sympathetic stimulation. And that's where you get the heterogeneities that you need to be able to set up VT circuits. And we actually also looked at this in our animal model and basically found that there were various norepinephrine levels, whether you looked at the scar, the border zone, or the viable myocardium, as compared to normal pig hearts, again, suggesting a gradient in norepinephrine and potentially sympathetic innervation. Back in 2004, when Cao and Peng Chen and Fishbein were looking at transplanted hearts at our institution, one of the things they noticed was that in patients with history of VT, in the border zones of their infarct, what they would find is these areas of localized sympathetic innervation, which they called hyperinnervation. This wasn't everywhere along the border zone. In fact, if you look at an infarcted heart, most of the border zone doesn't have nerves, but there are these regions where you will find these sympathetic nerve fibers. Again, so now, if you can imagine, if the sympathetic nervous system gets activated, you're going to have these cardiomyocytes shortening the action potential duration, whereas you're going to have the myocytes that don't have any more sympathetic nerve fibers not responding. And in fact, we showed this in human hearts using our duodecopolar catheters, where we basically got action potential duration recordings using a method called activation recovery interval in LAD infarcted patients that were undergoing VT ablation. And so we took these unipolar recordings, we basically calculated something called activation recovery interval, which has been shown to be a surrogate of action potential duration. It's sort of a non-invasive way of getting APD out of the heart that was validated by Lux and Haas about 30 to 40 years ago. And what we found is that when you gave isoproterenol, for example, there was a very different response in border zone regions versus scar regions versus normal regions in terms of changes in action potential duration. And then when you gave nitroprusside, it was even more interesting. Nitroprusside would basically drop the blood pressure and activate the sympathetic nervous system. That's essentially what it did in the normal patients that were just undergoing SVT ablation, right? Their action potential duration would significantly shorten. But in the diseased myocardium of a lot of these VT ablation patients, you had normal sites that would actually increase their action potential duration. You had border zone sites that would decrease their action potential duration slightly. And then you even have scar sites that were completely denervated that seemed to increase the action potential duration. And so this heterogeneity that we have seen in dog models and in pigs actually does also exist in humans undergoing VT ablation for their VTs. The other thing that I just want to point out real quick is that the nerve remodeling, sort of the denervation, hyperinnervation changes that we talk about at the level of the myocardium has really been the focus, but there is a great amount of extracardiac neuroremodeling that occurs as a result of myocardial infarction. And this data was done by one of my colleagues, Olu Ajujola, and what he did was he actually just took the stellate ganglia of the patients who had had cardiac sympathetic denervation. So this was the ischemic cardiomyopathy patients. This was the non-ischemic cardiomyopathy patients. And then he took some stellate ganglia from donor hearts, from donor patients that were having their hearts donated to transplantation. And he compared the changes that he saw in the stellate ganglia of normal patients as compared to ischemic versus non-ischemic cardiomyopathy. And he noted significant changes, some of which I've noted here, which was not only were the neurons abnormal looking in the ischemic and non-ischemic cardiomyopathy patients as compared to the normals. These neurons were larger, but they had sort of an increased level of synaptophysin immunoreactivity, which is a measure of how well synapses work. And the other thing that he noticed, which is not here, was that there was also significant amount of inflammation in the ischemic and the non-ischemic cardiomyopathy stellate ganglia that we had removed for cardiac sympathetic denervation as compared to the stellate ganglia that had come from the normal transplanted, the patients that were basically being donors for their of their hearts. And so this suggested that there were changes that occurred in the autonomic nervous system beyond the heart, potentially that helped to rev up the sympathetic nervous system and the stellate ganglia in terms of both inflammation as well as actual structural changes. And then there's actually been studies looking at responses of the insular cortex, which is one of the areas where autonomic modulation occurs, particularly the left, and so the sympathetic modulation occurs. And so when they did, for example, functional MRI studies of patients with heart failure as well as control, what they see are significantly abnormal responses at the level of the insular cortex and different regions of the insular cortex in heart failure patients as compared to control patients. Again, suggesting that the neuroremodeling that occurs as a result of heart failure, myocardial infarction, ischemic and non-ischemic cardiomyopathy goes beyond just the heart. It actually affects every level of the neuroaxis. And so that's really shown here. When you have myocardial infarction, we can also just think of it as any injury. You get both cytokines and neural growth factor, amongst other things, that are produced by the heart. At the level of a stellate ganglion will cause changes that we talked about, which is inflammation, changes in neurotransmitter and neuropeptide profiles of these neurons. At the level of the heart, you get denervation followed by reinnervation. The reinnervation is sporadic, and there's now data to show that the reason that happens is because the scar actually produces proteoglycans that inhibit normal reinnervation of the sympathetic nervous system back into this area. So what you end up is these local areas of nerve sprouts basically interspersed between areas where you have no sympathetic nerves. And so all of these changes, both at the level of the myocardium, the stellate ganglion, and then the afferent signaling that's going up to the brain and back down in the setting of sympathetic activation, the one day where that patient, let's say, is running to catch a plane, which nobody's doing anymore, but still, what you end up with is an increase in dispersional repolarization, EADs and DADs that are produced that lead to VTVF. And sort of this is kind of the global picture where we think where we think sympathetic modulation of ventricular arrhythmias occurs. It's really not just at the level of the heart, but really at every level of the neuroaxis. So knowing all of this, and if this is our diseased hearts that's continuously sending signals through the sympathetic chain up to the brain and back, and of course you have the neurohumoral factors that are involved at the level of the kidneys. Can we really modulate this? Can we really do something that is useful? And when we did this study initially, we were wondering about transplant patients, because those patients essentially get their sympathetic nerves as well as their vagus, right, cut. Their decentralized hearts when they get a transplanted heart. And the question was, well, if this is really something that's feasible, what is the incidence of VTVF in transplanted hearts? And this idea came about actually as a result of a patient that I was seeing now as a cardiology fellow, where we used to get treadmill stress tests on our transplanted patients every year. This patient came for his treadmill stress testing, and as soon as he started running on the treadmill, he went into pulseless electrical activity and collapsed. So he was transported over to the cath lab. And what they found in him, which is kind of not very typical of transplanted heart, where you often see diffuse transplant vasculopathy, but what they found in him was this focal stenosis at the level of the left main. And so this was really intriguing to us, because normally when you have a focal stenosis at the level of the left main, the presentation is VF, not pulseless electrical activity. And so we went back and we looked at all of our transplanted patients at that time to see what was the mode and mechanism of death in these transplanted decentralized hearts. And what we basically found is that even in the setting of acute ischemia, when we looked at all the rhythm strips of these patients that had had in-hospital cardiac arrest, only 10% had VF, the primary presentation of transplanted hearts in the setting of acute ischemia with either asystole or PEA. And so that made us think that potentially that decentralization that is occurring at the level of the sympathetics is helpful in the treatment of VTVF. And as many of you know now, by targeting this area, we have actually many neuromodulator therapies that are targeting this area to try to interrupt the sympathetic afferent and efferent transmission that occurs. And those include, and we'll go through some of the data here, with thoracic epidural anesthesia, stellate ganglion blockade, and cardiac sympathetic denervation. All of these are really trying to affect the same area of the neuroaxis to basically disrupt or inhibit the sympathetic nervous system in the setting of cardiac disease. So one of the questions is, well, what happens actually when you, let's say, put in an epidural catheter and you inject lidocaine at the level of T1, T2 thoracic spinal cord, where basically you would be disrupting efferent and afferent transmission to the sympathetic ganglia. what happens electrophysiologically. So we actually did the study in infarcted pigs. They all had a LAD infarcts, and we brought them back 6 weeks after their infarcts and looked at their electrophysiological parameters. And for the electrophysiologists in the rooms, what you see is an increase in the AH interval, that's the atrial ventricular conduction. You see an increase, no change, I'm sorry, in the HV interval. So the His bundle to ventricular time doesn't change at all. You see an increase in atrial effective refractory period and an increase in ventricular effective refractory period. So by doing thoracic epidural and by injecting lidocaine or bupivacaine into the space and disrupting the sympathetics, you're making the ventricular tissue more refractory. And when it's more refractory, it can't conduct and set up VTVF. The other thing that was notable was that, and we didn't expect, was that we actually did baroreceptor sensitivity testing in these animals. And what we found was that pre as compared to post-thoracic epidural anesthesia, baroreceptor sensitivity increased. Now you can see at baseline, these animals have kind of dismal baroreceptor sensitivity. You can give them all the norepinephrine or levofed that you want, and their heart rate really doesn't change. But post-thoracic epidural anesthesia, there did seem to be a better response, suggesting that by now interrupting those sympathetic afferents that are going through the spinal cord up to the brainstem, you're actually modulating vagal outflow so that you actually have increased parasympathetic tone potentially by modulating the sympathetic nervous system. And we followed up these studies by trying to block just the sympathetic nociceptive fibers. Those are the ones that transmit information about all the pain as well as toxic molecules that are sitting around, such as CGRP. And we use racinoferritoxin, which is a specific nociceptive afferent blocker. Now, racinoferritoxin is actually nothing more than a very, 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 very hot chili pepper. And for those of you who cook, this is the Scoville scale. And what you can see, for example, is sweet bell pepper is down here. And, you have sort of your chili peppers, super chili peppers over here. And then here's pure capsaicin at 16 million Scoville units. And then here's racinoferritoxin. So racinoferritoxin is so hot that it basically sort of, if you want to think of it as, burns up the sympathetic afferent fibers. And so we applied this now at the level of the epidural space. We basically injected racinoferritoxin into the epidural space and looked at baroreceptor sensitivity. And what we found is that pre as compared to post RTX, our baroreflex sensitivity increased, suggesting that it's not just sympathetic afferents, but specifically sympathetic nociceptive afferents, those fibers that are responsible for transmitting information about sort of the oxidative reactive species that are going on in the heart, as well as just pain and respond to other things like bradykinin that are mediating the decrease in vagal outflow. And if you block that, you can potentially improve baroreceptor sensitivity. So what about the human data? So there actually isn't huge, large series of patients that have undergone thoracic epidural anesthesia for management of VTVF. Partially that's because sort of at different centers, you need to have specific anesthesiologists that are familiar with doing this procedure, but more importantly, they also have to be comfortable with doing it in patients who have significant heart failure or are incessant VT. And so when we looked at sort of in general, our experience, we had 11 patients total. 4 of them had VT storm, 7 of them had had incessant VT. They had already gone through sort of all the general things you think about, which is they'd been tried on antiarrhythmic drugs, their ICD had been reprogrammed, they'd already been intubated and sedated. We had actually tried in many of them to try to intervene, but because they were so unstable, hadn't been very successful. And so one of the things we looked at is what was the efficacy of thoracic epidural anesthesia in disrupting their VTVF. And on this panel, you have number of ventricular tachycardia episodes. This is pre-TEA. This is 48 hours post-TEA. And there's a significant decrease in the number of VT episodes after TEA. One of the things that I think the anesthesiologists always worry about is what happens to the blood pressure when you put in lidocaine or bupivacaine into the epidural space and you block the sympathetics. And in this study, we actually really didn't see a significant change in mean arterial blood pressure post as compared to pre-TEA. when should TA be considered, and then when should it not be considered, I think is an important it's important to go through the thought process. And here we basically consider TA if you have incessant VT despite 2 antiarrhythmic agents, if you have continued VT storm, either despite an initial attempt at ablation, or you just can't get the patient stable enough to get them down for their ablation. If you notice a decrease in VT burden due to deep sedation, I think that's a really good time to consider TA, because then what you can do is place a TEA and wean the sedation. And then the patient is awake and can talk to you, and they can actually be a part of whatever decision-making process is going on, which may be repeat ablation versus LVAD versus transplant. The absolute contraindications, I think, to TEA are an active infection, if they're on dual antiplatelet therapy and you can't interrupt it, or if they're on dual anticoagulation therapy. I'm sorry, not dual, just anticoagulation therapy, and you can't interrupt it. And of course, the relative contraindications are sort of the things that we think about, which is sort of they need emergent procedures for something else like acute myocardial infarction, and you need to give them blood thinners for that other process that's going on. The next, I think, sort of intervention that has been shown to work in the setting of acute VTVF is stellate ganglion blockade. Now, you could do this under ultrasound guidance, or you could do it under fluoroscopic guidance. And in this paper, they used a posterior approach, but some of our surgeons have actually sort of used the supraclavicular approach to try to get to the stellate ganglion. Now, this is a study out of the Mayo Clinic that was published in 2019, and they had 30 patients with basically refractory VTVF, and they did stellate ganglion block in those 30 patients. Then they compared the patients that had resolution of their ventricular arrhythmias within 72 hours after stellate ganglion blockade versus no resolution of their ventricular arrhythmias within 72 hours after stellate ganglion blockade. And actually, interestingly enough, they really didn't find any baseline differences. So they didn't find any predictor that could tell them ahead of time when they did stellate ganglion blockade whether it was going to work or not. All of these patients kind of had relatively low EFs. They all had significant comorbidities overall, suggesting that sort of you just have to try it in order to know whether it's going to work. However, despite all of that, if you looked at the 72 hours before versus the 72 hours after the procedure, most of the patients did have a significant benefit. Even if they didn't have resolution of their arrhythmias, they had a significant decrease in the burden of their arrhythmia episodes, as well as defibrillator shocks. What was interesting about this study is that they actually reported some of the follow-up of what happened to these patients that got stellate ganglion blockade, which is kind of unusual. Most case series just look at that brief, let's say 72 hours before versus 72 hours after. What they showed is that there were, after 38 plus or minus 40 hospital days, so long hospital durations, 23 patients were discharged. 23, I don't know if you recall, out of 30. So that means 7 were not discharged. At a meaning, or that basically they died. At a mean follow-up, 22 plus minus 16 months, 3 of the patients that had been discharged actually had undergone OHT. Again, at that follow-up, 5 died, and the causes of death were septic shock, renal failure, heart failure, stroke, or an unknown cause. And 10 underwent catheter ablation during follow-up. 1 of their idiopathic VF patients underwent left CSD, and actually that patient, according to the report, did pretty well. And of the 20 patients who survived to hospital discharge and did not undergo transplant, 50% were free from recurrent VA after discharge, but 5 had already had ablation. And the other 10 patients continued to have recurrent VA, even though 5 of those had also had repeat ablation. It just had not worked. So at least, if nothing else, this seems to be a decent measure, decent temporizing measure. And that's what really has been shown in the subsequent meta-analyses of all the different case series and case reports that have been done, is that you do get a significant decrease in arrhythmia episodes after stellate ganglion blockade as compared to before stellate ganglion blockade, even if for every patient it doesn't exactly go down to 0. And that does allow you to seem to stabilize a patient enough to be able to use this as a temporizing measure and to get them to whatever the next step is. And even here, and there doesn't seem to be any significant sort of hemodynamic problems. Their ejection fractions, for the most part, seem to stay the same. Their blood pressures don't significantly change. And then on another meta-analysis that was done in 2017 now of 35 patients, here they broke it down by, did it make a difference if you did unilateral versus bilateral? Now, we're obviously advocates of bilateral, and in my opinion, N=4 is not enough to really make a decision, but you do seem to get enough benefit with just unilateral stellate blockade. So it's worth just doing the left stellate ganglion block if you're not able to get bilateral stellate ganglion blocks. And in this study, in these sort of meta-analysis, they didn't notice a difference in terms of results when it came to ischemic versus non-ischemic cardiomyopathy patients. Both seemed to benefit post as compared to pre-stellate ganglion blockade. And there wasn't also a difference between monomorphic versus polymorphic VTVF when it came to episodes of arrhythmias. What they did report, though, is sort of for the patients that had follow-up noted in their studies and at discharge, there really doesn't seem to be a significant survival benefit to stellate ganglion blockade purely and alone. I guess that's not really surprising. We still have a study to show that there's mortality benefit in a randomized trial for VT ablation, but nevertheless, something to keep in mind that for now, this seem to be a temporizing measure, but they overall seem to do well. So you might actually see a benefit from the stellate ganglion blockade that goes beyond the 72-hour period and what you'd expect would be the effect of the anesthesia. And that may be related to not just the fact that you are maybe potentially taking them for VT ablation and evaluating and upping their antiarrhythmic drug therapy, but also potentially to the fact that if you can disrupt VT storm, that actually helps the patient. If you can disrupt that sort of sequence of continuous defibrillator shocks, that potentially in itself has beneficial effects long-term. Very quickly, I just wanted to move on to bilateral stellectomy and cardiac sympathetic denervation and discuss some of those studies. Here, just sort of in our animal model, if you do stellate ganglionectomy, you put the sock on the heart and look at your action potential durations, what you'll see is an increase in action potential duration, again, suggesting that cardiac sympathetic denervation, bilateral stellectomy, all of these procedures make the tissue, again, more refractory. You also note changes that occur in activation. So pre-CSD as compared to post-CSD, when you pace the scar or border zone regions, you notice that areas that previously were areas of line of block now kind of have more uniform conduction. This isn't really likely because you have gotten rid of this area block. What it usually means is that you've also slowed down conduction sort of in these surrounding regions equally. And so now you have more uniform activation that can help you when it comes to circuits of VTVF. And then you do get an acute decrease in VT inducibility in animal models, even immediately post-stellectomy. But what about in patients? So there have been some smaller series, but the largest series of cardiac sympathetic denervation in patients with structural heart disease was done in 121 patients. This was a multi-center registry. And I think some of the things to note here was that these patients were quite sick. Their EFs were about 30 plus or minus 12%. Most of them had non-ischemic cardiomyopathy. So 2/3 had non-ischemic and only 1/3 had ischemic cardiomyopathy. And the median number of ICD shocks in the 6 months prior to the procedure was 10. 38% had polymorphic VT and 75% had a presentation with VT storm. In this series, because it was a multi-center series, actually 20% of the patients only had left cardiac sympathetic denervation only. And what we found here was that there was a significant reduction in the number of ICD shocks in the year after the procedure. That's what the post-CSD period is, as compared to the 6 months prior to the procedure. This reduction was over 80%. And there was a 58% ICD shock-free, transplant-free survival at 1 year, despite the fact that many of these patients were very sick. Like I said, 75% had presented with VT storm. The other thing that we noticed is that the bilateral cardiac sympathetic denervation patients seem to do better than the left-sided patients alone. And so basically now we aim for bilateral in every patient, unless there is a problem. We think they have adhesions on one side versus the other, in which case we always start with the left, and because there's just more data for the left stellate ganglion, and then we move on to the right. We usually try to do it at the same procedure so that they don't have to keep coming back. There are some, quote, complications and side effects to be aware of to cardiac sympathetic denervation. Obviously, this is a procedure that's done through VATS, a video-assisted thoracoscopic approach. And so there's about a 2% risk of hemothorax. They can have pneumothoraces that occur. Ptosis, surprisingly, hasn't been much of a problem. This is sort of the most common side effect you read about in textbooks, but we haven't seen a whole lot of it. And what we've seen has been very mild and for the most part has resolved by 6 months. Some of the patients, up to 13%, will require vasopressor support up to 24 hours to 48 hours after the procedure. And then there's sort of the other things you think about when you think about procedural complications, which is they can get cellulitis, they can have nausea, vomiting from the anesthesia, so on and so forth. What we wanted to know was, were there any predictors for patients that did not do well with cardiac sympathetic denervation? Like, who should we avoid this in? And perhaps not surprising, we found that the patients that had presented with NYHA class 4 were more likely to recur after their cardiac sympathetic denervation and need other therapies, suggesting that maybe these patients who, when they first come in with their VTVF after their cardiac catheter ablation procedure, should be referred rather than waiting till they were essentially bed-bound and NYHA class 4 on multiple pressors. The only other potential sort of risk factor for recurrence of VT after cardiac sympathetic denervation was VT cycle length. So what we found is that patients who have slower VTs, and by slower VTs is generally those that are less than 150 beats per minute, they don't seem to do as well after the procedure. Whereas patients who have much faster VTs are the ones that seem to benefit. Something to keep in mind. The last thing I just wanted to point out when it comes to cardiac sympathetic denervation is that 37% of the patients that we talked about in the previous study had polymorphic VT. And so one of the questions we had as a center was, well, if we took away all those polymorphic VT patients, would cardiac sympathetic denervation still show a benefit? And so what we did in this study was we looked at a study cohort of 404 patients referred for VT ablation that only had monomorphic VT. If they had any presentation with polymorphic VT, or if they had combination of polymorphic and monomorphic VT, they were excluded from the study. And then we looked at the subgroup that subsequently underwent cardiac sympathetic denervation to see if cardiac sympathetic denervation really had a benefit in the subgroup of patients with monomorphic ventricular tachycardia. To do this, because every patient basically at our center now that has refractory VT that doesn't respond to catheter ablation, at least on a second or third occasion, gets cardiac sympathetic denervation, we had to come up with a model first. So we came up with a model to try to see what were the risk factors for VT recurrence after catheter ablation in general. And as you can imagine, some of the things we already know, non-ischemic cardiomyopathy, VT storm, emergent indication, and higher NYHA classes were risk factors for VT recurrence after catheter ablation. Now, all the CSD patients are sort of in this period, in this type, suggesting that they're very sick. And so their risk of VT recurrence should be high just based on their baseline comorbidities. And so to basically adjust for that, we took those 69 patients, put them in this model, and we compared what would have been their expected risk of VT recurrence here shown in red, based on their significantly worse comorbidities, to what was their observed risk of VT recurrence after CSD. And what we found here is that the observed risk of VT recurrence was significantly better as compared to what would have been expected just based on their comorbidities coming in for VT ablation prior in the time of presentation. So basically what we've concluded from the study is that, even patients with pure monomorphic scar-mediated VT, if they've failed their VT ablation, are likely to benefit from cardiac sympathetic denervation. I'm going to skip this slide just for time because I do want to spend a little bit of time talking about renal denervation as sort of the other neuromodulatory therapy that I think is sort of accessible for electrophysiologists, but does need additional studies. So, the kidneys also will sense a decrease in cardiac output, and they will send afferent signals through, different types of ganglion, including the celiac ganglion, through the sympathetic change of the spinal cord. And this does lead to sympathetic activation through the kidneys and the adrenals, which causes the renin-angiotensin system to get activated, but also releases epinephrine and norepinephrine that can be proarrhythmic. And the changes that can occur with neuroendocrine activation are pretty well established. There's increased fibrosis, gap junction remodeling. There's the proarrhythmic effects of the catecholamines, which can cause triggered activity and increased dispersional repolarization. And then there's altered electromechanical feedback because of the volume overload and hypertension that occurs as a result of angiotensin. So the kidney and the heart are indeed linked. And there have been studies that were performed back in the 1980s that showed that if you stimulate the sympathetic afferent fibers at the level of the heart, you will actually see changes in renal sympathetic nerve activity of dogs. So you're stimulating the heart and you'll see changes in the kidneys. And other studies that looked at nerve recordings at the level of the brainstem and showed that renal afferent stimulation actually affects firing of medullary and hypothalamic neurons in the same areas where cardiac neurons are located in cats. So that there does seem to be both an afferent and an efferent link when it comes to the heart and the kidneys. And so the question is, can we, with renal denervation, modulate this afferent and efferent outflow and have beneficial effects? And so some of the initial studies that looked at this were quite small. This was just a study of 4 patients who had failed catheter ablation and looked at the number of VT episodes pre as compared to post-renal denervation, and again showed a decrease in these number of episodes that for a lot of the patients seems to sustain, but again, only 4 patients here. This was followed by a study that was published in 2015. Now, this was a study of 10 patients. Most of these patients had Chagas cardiomyopathy. They had Chagas disease. And if you actually look at this population, most of these patients did not undergo catheter ablation. So the effect that you were seeing was purely related to the renal denervation procedure that was performed. So what these authors reported is that in this population, predominantly made out of non-ischemic cardiomyopathy and Chagas disease patients, there was a significant decrease in the number of VT-VF episodes at 1 month as compared to 6 months, which I think is pretty impressive, again, given that most of these patients did not have catheter ablation. And there have now been other studies that have tried to look at the effect of renal sympathetic denervation. This was a study that looked at propensity score matching, a group that only had catheter ablation versus renal sympathetic denervation plus catheter ablation, performed sort of in an adjunctive manner. And they did note a decrease in the mean number of VT episodes in group 1, which was the catheter ablation. In group 2, which was a catheter ablation plus renal denervation group as compared to group 1. So you can see here at 3 months, 6 months, 12 months, and 18 months, group 2 that had the renal denervation group had significant less VT-VF episodes. Though in general, they didn't notice a decrease in mortality, which you wouldn't expect with just 16 patients in both groups. There have been other studies that have looked at this also as an adjunct to cardiac sympathetic denervation. And I'm just going to point out that in these 10 patients, the main thing we found is yes, renal sympathetic denervation decreases the number of ICD therapies and ICD shocks. But just to point out that it seemed like the patients that got the renal denervation as an elective procedure as compared to those that were getting it in the setting of VT storm when CSD and VT ablation had all failed seemed to do better. So think earlier. There are definitely limitations to renal sympathetic denervation. We don't really know what we're denervating when we put the ablation catheter in the renal arteries. There have been careful studies that have looked at where the nerves are located. And I think some of the things that I've found is that you're more likely, so that this is the distal areas into the renal artery, to find nerves closer to the lumen in those distal regions. But those are the regions we try to avoid because of risk of dissection. They've also shown that there's actually more likely to be nerves on the ventral as compared to the dorsal aspect of the heart. And actually you find more nerves on the ventral and, sorry about that, dorsal aspects as compared to superior and inferior aspects. And if you're doing renal denervation, generally what most of us do is just point our catheter up and down. Maybe what we should be doing is pointing it anterior and posteriorly to get most of those renal nerves denervated. The last thing that I just want to talk about is that there's now studies on these hotspots within the renal arteries where you can stimulate and either get a pressor, meaning an increase in blood pressure, inhibitory, a decrease in blood pressure, or neutral spots. And there's a suggestion that the pressor spots are the ones that you should be ablating, sort of at least trying to give us an endpoint. The last thing is that, when we do renal denervation, there are lots of structures around our renal arteries that we're not aware of. That includes lymph nodes and blood vessels. Lymph nodes tend to attract heat. And so lesions that are around lymph nodes kind of tend to go towards the lymph node and are larger. Whereas blood vessels tend to, detract heat. Basically, the heat, they have a cooling effect. So nerves that are located around lymph nodes would be better ablated than nerves that are located around blood vessels. And that's, again, another problem with renal denervation, where you're essentially trying to denervate regions where you don't exactly know where the nerves are located. But I do think this is a promising approach as an adjunct, particularly catheter ablation. It can often be done using the same ablation catheter, and so potentially can be a tool that the electrophysiologist can use in those refractory patients. So at the end, I just wanted to thank the people currently in my lab, the people that have been in the lab in the past who've done a lot of the mechanistic work that I talked about, as well as our collaborators kind of both at UCLA in the United States and then over in Europe, and then our funding organizations. And of course, the UCLA Cardiac Arrhythmia Center and its faculty, as well as our cardiomyopathy and surgery attendings, without whose collaboration, none of the human work would be possible. Thank you. I hope I left at least a few minutes for questions.
Yeah, we've got a few minutes, and that was a great talk, Marmar, especially the way of looking at arrhythmia management that we typically don't think of. There's a few questions in the chat box, so I will start with one of the more recent ones that was from Dr. Raj. Do you think that central sympatholytics could be helpful, like clonidine or methyl-dopa, or is that too untargeted in terms of decreased sympathetic activity?
So central sympathetics can be helpful if you can deliver them to the right location. Absolutely. In fact, Doug Zipes did a study, I believe, with intrathecal clonidine and showed that you could decrease VT-VF episodes. So the answer is yes. It's just that, but that was a dog study. So to convince patients to come and get intrathecal clonidine in humans, I think is a little bit more of a challenge. And it hasn't been tested in patients in the same sort of way. But yeah, I think that central sympathetics are helpful. And that's essentially what you do when you intubate and sedate a patient, right? You take the central nervous system out of the picture. And that in itself is helpful in suppressing VT-VF.
Okay. And there's some discussion early on in the chat box of when you were talking about TEA, what happens to sort of the baroreceptor sort of sensitivity, or did you guys check that?
Yeah, so we checked it in pigs. We haven't checked it in humans. But in the infarcted pigs, baroreceptor sensitivity improved, which was one of the surprising findings, right? We knew that we were probably going to get electrophysiological changes, like increase in effective refractory period of the atrium or the ventricle, as you might expect when you do sympathetic blockade. But we didn't expect baroreceptor sensitivity to improve in these infarcted animals. And I think that's because when you have sympathetic afferent activation, so that really generally is thought of just increasing sympathetic efferent outflow to the heart. But in reality, I think that afferent stimulation gets to the NTS, right? And then can actually go ahead and block, actually through multiple pathways, the vagal nuclei. And so that can actually inhibit parasympathetic output. So it's sort of like you're not just, raising the sympathetic bar, you're also just killing the parasympathetic bar over here. And that's what leads to your vagal imbalance.
Cool. One of the questions I had, which you kind of alluded to earlier, was when you do a left parasympathetic ganglion block, typically using something like lidocaine, that's not going to have, you're not expecting some sort of permanent effect. But there seems to be a small subgroup who, even if you don't give definitive treatment afterwards, they have the reduction in arrhythmia stays. Is that some effect from interrupting the parasympathetic system, or is it maybe just that if you get people through the VT storm, some of them will go back to regress to their baseline regardless?
So really good question. It hasn't really been looked at very carefully, right? Like basically when people do sympathetic blockade, if the patient starts to do well, generally they send them for ablation, or generally they'll be like, okay, now you're stable, here's more amiodarone, or here's your transplanted heart or your LVAD. But I can't attribute the effect of lidocaine to being long enough to really make neuronal remodeling at the level of the sympathetic ganglion better, right? Because it's not really long enough. But so I do think it has probably at this point more to do with the effect of VT storm. I think John Sapp published a study a year ago in JACC Clinical Electrophysiology that showed that VT storm begets VT storm. that patients who have significant arrhythmia episodes within 24, 48 hours are likely to do worse and have more arrhythmia episodes. And so potentially if you can just put a lid on that and cool that down earlier rather than later, that by just suppressing their VT storms and their defibrillator shocks, they can do better in the long run. But those are all studies that we're currently doing. So we have pigs that are running around actually with sympathetic stellate ganglion block catheters. So you can actually do continuous infusion. There's nothing that says, by the way, that when you do your stellate ganglion block, it has to be an injection. And in fact, the people at OHSU, Oregon Health Sciences Unit, just have a paper in press where you can actually put your catheter and then hook it up to a pump if you need to. And you can continue to infuse your lidocaine and bupivacaine as needed, or you can unhook it and then only administer when needed, sort of like the way you would have any other catheter. So, and there hasn't been sort of any side effects or injury or complications reported from that. So you can get sort of long-term benefit, even if you needed to, for more than just a day or 2 or 3. You can keep the catheter in and infuse for longer periods.
You should get a system that actually looks at the baroreflex sensitivity. So when it goes under a certain threshold, then it triggers the infusion pump to just.
That's a nice feedback.
Get the, you know, a feedback loop system, and then just get it done. Because you already showed that baroreflex sensitivity probably is going to be the protective mechanism, or, you know, the way you can actually look at it. That was a beautiful lecture. You know, makes me think that that's my next sabbatical. So you touch on a lot of points, and you only told us the yin story of the yin and yang part. So we're going to invite you back to talk about the vagal part, because that's also fascinating. I got one question. I have to run to clinic, sadly, but you know, there's a lot of things you touch on that are fascinating. But how about the nerve sprouting part? Because, you know, the nerve sprouting is amazing, and there's some natural reinnervation that happens. So how does reinnervation play a role on modulating these VTs? And is that something that we can manipulate through nerve sprouting?
Okay, so really excellent question. Most of this work that's coming out of nerve sprouting and inhibiting it or promoting more uniform neurotransmission is actually being done by Beth Habecker, again, at OHSU. She's one of the neuroscientists, neurophysiologists up there. And what she's noted is that in infarcted mouse hearts, you'll get this nerve sprouting in localized regions. That's not surprising, right? These are peripheral nerves. They're not central nerves. So they're going to try to grow back, and they're neuronal cell bodies that are living at the level of the stellate ganglion or the middle cervical ganglion or the thoracic ganglia are not damaged. The cell bodies are active, and they're going to try to grow back and basically re-innervate the scar in the same way that, let's say, the heart used to be innervated before the scarring occurred. The problem is what she noted was that there were specific molecules that were produced by the collagen and the scar and the fibrosis. They're specific proteoglycans that seem to inhibit the nerve fiber re-innervation. They bind to the BDNF receptors and the receptors that that these nerves need to regrow completely back into the scar. And then what she found is that if you now inhibit those proteoglycans that are inhibiting the re-innervation, and you get more uniform re-innervation into that scar, you now have decreased ventricular arrhythmia episodes in response to isoprosternal in these mouse hearts. So
there you go. So you got to do a double negative to get a positive.
Right. If you could inhibit the stuff that's preventing those nerves from at least being able to grow back normally, right? Then potentially that could also be an antiarrhythmic target. Absolutely.
So does that homogenize the dispersion of refractoriness?
So no, because sympathetic nerves can't be perfect, right? Not every myocyte is going to get the same exact sort of input, right? As the
but I mean, it reduces the dispersion.
It does reduce the dispersion. So when you stimulate the stellates in a normal heart, dispersion does go up because the nerves are not homogeneous exactly everywhere. But when you stimulate the stellate ganglion in a diseased heart, the dispersion of vaporization is significantly worse than in a normal heart.
And what about the conduction slowing? Does it also change that?
Potentially. So she looked at that using calcium imaging and was able to show that there was sort of a more uniform activation of the heart.
Well, that's great. I'm going to blame you for being late for clinic.
Yeah, I think we'll stop anyway. It's after 9 o'clock. Well, thank you, Dr.
That was a beautiful lecture. Thank you.
My pleasure.
We'll bring you back for the vagal part.